Hello, everybody, and welcome to another year of Grand Rounds lectures. We're so happy to have everybody with us. As in the past, I'll encourage those of you who have cameras with you to keep your video on whenever we can. I'll turn mine off so I can chew a little bit, but otherwise I'll do my best to keep my camera on. Thank you all for joining us. Thank you for your feedback this summer. We heard a lot of interesting feedback about what has worked well and less well in Grand Rounds over the last couple of years. And so we've been working very hard with the chief residents to really put together a tremendous buffet of choices of speakers for this year, and delighted to have all of you join us for that. And in particular, one of our goals for this year is to make sure that our alumni are featured. And so we are particularly thrilled to have an alum, Dr. Yuichi Shimada, here with us today. Many of you remember him, and many of you know that he's an assistant professor and the director of research for the Columbia Hypertrophic Cardiomyopathy Center. After getting his medical degree at the University of Tokyo, he was a medicine resident and a chief resident here from 2008 to 2011. And then went to the Harvard system for cardiology fellowship and specialized training in hypertrophic cardiomyopathy, and then did an advanced echo fellowship at Columbia. And while doing all of that, got his MPH from Johns Hopkins. He's written 60 peer-reviewed scientific articles, which have been cited more than 1,400 times. He just received a R01 grant from the NIH. I mean, I can't say enough nice things. We are thrilled to have him answering this important question about whether, I guess, hypertrophic cardiomyopathy is in fact the most interesting heart disease. Dr. Shimada, take it away.
All right, thank you so much for your introduction, Dr. Weissman. Hello, everyone. My name is Yuichi Shimada, and it's true, I used to be an internal medicine resident and chief resident at Beth Israel, so I'm very thrilled to be back. Although it's virtual, I do feel that I'm back here. And today I'm going to talk about hypertrophic cardiomyopathy, which in my opinion, is the most interesting heart disease, and I'm going to try to convince you to feel the same way. So here are my disclosures. And there are three parts in my presentation. Part one is the introduction of hypertrophic cardiomyopathy. And then part two is the diagnosis, and the part three is management of hypertrophic cardiomyopathy. So let me start with a case of a 22 years old male, young athlete, basketball player who died after collapsing during a game. So, and as you can see on this newspaper article, autopsy revealed that he actually had hypertrophic cardiomyopathy. As you can see in this case, sudden cardiac death can be the first manifestation of HCM. This pie graph shows causes of sudden cardiac death in young athletes. And as you can see from this graph, here is HCM and constitute 35% of the causes, different causes of sudden cardiac death. So based on this, the HCM is the most common cause of sudden cardiac death in young athletes in the US. So this leads to the first take-home message of the day. And I'm saying that this is the most common cause of sudden cardiac death in young athletes in the US, but it's actually in the young, not only athletes, but in the young below 30 years old in the United States. And I'm saying in the United States because it's a little bit different in Europe, especially like Italy, the most common, maybe like arrhythmogenic RV dysplasia or something else. But in the US, it is the most common cause of sudden cardiac death. This is a gross pathology of hypertrophic cardiomyopathy. And here's the left atrium, and here's the mitral valve, you can see here, and here's the left ventricle, which is pretty thick, and here's the aortic valve, and you can see this left ventricular outflow tract just below the aortic valve is pretty narrow. And the interventricular septum, IVS, is very, very thick. The upper limit of normal for male is like, on echo, is 10 millimeter. It's for female, it's 9 millimeters. So this is like almost looks like 3 centimeter. So it's pretty thick. As well as the posterior wall, this is also thickened. And if you take a closer look, there you see some like white dots here. This is an interstitial fibrosis in the submyocardial, subendocardial area. These pictures show the microscopic findings in normal on the left and patients with HCM on the right. The myocardium in the normal subject is aligned in an orderly fashion pretty well. In contrast, the alignment of the myocardium is bizarre here in HCM. This is what's called myocyte disarray in HCM. And then microscopically, you also sometimes see interstitial fibrosis as well. Now, on how many mutations and genes have been discovered to be responsible, meaning pathogenic for HCM? In the past, we used to say that there are more than 200 mutations in more than a dozen of genes, mostly coding for proteins in the sarcomere. Then I had to change the slide because more mutations were identified, and even more mutations have been identified, and more. At this point, I felt that this is kind of something like this, like McDonald's started to say served over 1 million, and then said over 99 billion, and now they say billions and billions. And then at this point, we have over 1,500 mutations in more than a dozen genes that are responsible for hypertrophic cardiomyopathy. And we can find most of the time, we can find mutations in familial cases and early onset sporadic cases, so early onset non-familial cases. However, the detection rate decreases to like as low as 20% in late onset sporadic cases. There are several limitations in genetic testing in clinical application of genetic testing data in hypertrophic cardiomyopathy. First of all, there are, as I said, there are so many genes with so many different kinds of mutations, making it challenging for us to interpret the significance of each mutation. Second of all, about 50% or more of patients with HCM has no identifiable mutations. And third, the genetic clinical correlations are weak. So even family members who share the same mutation may have different phenotypes. And this is probably because of like modifier genes and environmental factors. I had an astonishing case of 2 sets of twins. So there were 2 sets of twins in one family, and they shared exactly the same mutation. But one brother did not have any phenotype at all, and the other had a lot of phenotype like ventricular tachycardia, sudden cardiac death, and it required an AICD implantation. So this highlights the weak correlation between the genetic mutation and clinical phenotypes. Lastly, genetic testing, I wouldn't say is expensive, but can be expensive depending on what insurance you have. Without insurance coverage, it costs about a few $1,000s. So how much the patient has to pay out of pocket really depends on what kind of insurance they have. Moving on to the second part of the presentation, I'll talk about the diagnosis of hypertrophic cardiomyopathy. The diagnosis part is probably more important for you guys as a medicine resident than the therapeutic or management part, because you are the front line, right? Seeing a lot of patients. And so you may be the one who makes the diagnosis for the first time in the patient's life and refer to cardiologists or manage those patients in your clinic. So I'm gonna ask some questions for you later on. And then to answer my question, you can just put like your message to chat. If you don't feel comfortable messaging to everyone, you can just message to only me. or you can just unmute yourself and shout the answer. So let's get started. First, HCM, hypertrophic cardiomyopathy, is characterized by left ventricular hypertrophy without other conditions that can cause the same degree of hypertrophy. So LV hypertrophy out of proportion to like other loading conditions such as blood pressure. Sometimes it could cause right ventricular hypertrophy as well. The prevalence is 0.2 to 0.5%. In other words, 1 in 200 to 500 people are affected by HCM. Imagine that during your residency or maybe fellowship or during your career, you see thousands of patients, right? And if 1 out of 200 to 500 people are affected by HCM, then you can probably see at least a few during your residency. So just make sure to get some features from my presentation, and then make sure you do not miss those patients with HCM because they are very, very underdiagnosed. Sometimes there are sporadic cases. However, HCM is often familial with autosomal dominant pattern of inheritance. It can lead to diastolic dysfunction and heart failure, ischemia, even without coronary artery disease, arrhythmias such as atrial fibrillation, ventricular tachycardia, and ventricular fibrillation, and mitral valve abnormalities. It can cause left ventricular outflow tract obstruction or LVOT obstruction in some patients, and these cases are called hypertrophic obstructive cardiomyopathy or HOCM. A lot of people call HCM as HOCM because it's easier to pronounce HOCM, but HOCM is actually reserved for obstructive form of HCM, not just HCM. Then why do patients with obstructive HCM get symptoms? The key component is SAM, or systolic anterior motion of the mitral valve leaflets. When you have asymmetric septal hypertrophy displayed here, then the LV outflow tract written here gets obstructed. It creates faster blood flow through the LVOT. In that case, the anterior leaflet of the mitral valve gets dragged anteriorly, which is SAM, right? The systolic anterior motion of the mitral leaflet, and further narrows the LVOT, left ventricular outflow tract. If the anterior leaflet gets dragged further, then the coaptation between the anterior and posterior leaflets gets lost, and this results in mitral regurgitation as displayed here. So because of these, patients can get dyspnea and other symptoms of heart failure, mainly due to diastolic dysfunction plus minus mitral regurgitation. They can also get angina even without significant coronary artery disease because the myocardium is very, very thick and oxygen supply gets impaired in the subendocardial area. They can also feel palpitations from arrhythmias. They may complain of lightheadedness, dizziness, pre-syncope or syncope, and these are most often due to LV outflow tract obstruction. However, they may be due to ventricular tachycardia. The most feared symptom of hypertrophic cardiomyopathy is sudden cardiac death. And as I said, this can be the first manifestation of the disease. On the physical exam, you may feel brisk carotid upstroke and a forceful LV impulse. There may be S4. You sometimes hear murmur in obstructive form of HCM. This is due to LV outflow tract obstruction, mitral regurgitation, or maybe both. Murmur due to LVOT obstruction gets louder with Valsalva maneuver. And this is because the LV becomes smaller due to decreased preload, and the LV outflow tract obstruction gets worse. So here's your take-home message number 2. There are only 2 cardiac conditions whose murmur increases with Valsalva maneuver. One is, as I said, obstructive form of hypertrophic cardiomyopathy, and the other is mitral valve prolapse. This is kind of high yield in the USMLE and also medical board, and also actually cardiology boards. All right, let's talk about EKGs. So EKG in patients with HCM can show essentially anything and everything. This is kind of more typical EKG of hypertrophic cardiomyopathy, showing left ventricular hypertrophy with strain pattern. See ST depressions, downsloping ST depressions, strain pattern. This one is showing QS pattern in the V1. You see no R, right? It's Q and S, and V2 and V3. Let me just shrink my screen. Yeah. So this, if you are shown this, then you would think that, oh, this patient may have had prior myocardial infarct in the septal and anterior distribution. And we know clinically that he did not, because we did cath and he had a pristine coronary artery. So this is pseudo infarct pattern. In this particular case, it's a pseudo anteroseptal myocardial infarction pattern. So HCM could do this to the EKG. This is another example of patient with hypertrophic cardiomyopathy. You can see Q waves in the inferior leads, right, 2-3 AVF, and then kind of tall R wave in V1, V2. So as you know, this is inferior infarct pattern, and what the infarction of what area causes tall R in V1, V2? It's posterior infarct, right? So this is pseudo inferior and posterior MI pattern caused by hypertrophic cardiomyopathy. Again, this patient does not have a history of MI or does not have any coronary artery disease. This is all HCM doing this to the EKG. Next one has QS pattern in the anterior or septal leads, V1, V2, and then also QS pattern in the inferior leads. So this EKG is showing a double infarct pattern, anteroseptal and inferior. And the next one, it looks a little bit scary because those T waves look pretty peaked, right? So this is typical for the hyperacute T in the STEMI. Before ST elevation, if you catch them in the hyperacute phase, you see this very tall, peaked, looks like it's pretty sharp, and it's going to be painful to sit on T wave. But this is this patient's baseline EKG, and this is done. These changes are caused by hypertrophic cardiomyopathy, but not ischemia. So HCM could do this to the EKGs. And this patient has an apical and lateral T-wave inversions even without the presence of ischemia. And this one is a good one for the pocketbook. One EKG to remember from today. So this is showing pretty deep, very deep T-wave inversions, 2-3 VF, but more importantly, they like V4, V6, maybe V4, V5. This is called giant negative T-wave. Can anyone guess what subtype of hypertrophic cardiomyopathy this is? You can send a chat to me, or if you feel comfortable, everyone, or you can unmute yourself and shout the answer. What subtype of hypertrophic cardiomyopathy is this EKG typical for? Giant negative T waves. in the apical leads. All right, yeah, the answer is the apical subtype of hypertrophic cardiomyopathy is giant negative T waves. Those are typical for apical form of HCM. All right. So this one looks like the patient is having ST elevation MI here and there. But this is their baseline EKG. This patient is not having chest pain or cardiac ischemia, but this is HCM that's causing these ST changes. So our practice or advice to the patient is to give a copy of EKG to the patient so they can carry the EKG in their wallet. Otherwise, what happens if this patient comes to the ED with chest pain? They're gonna cath them, right? Yeah, those people sometimes get emergent cardiac cath for atypical or non-cardiac chest pain just because this their baseline EKG has ST elevations. So we ask the patients to keep the EKG in their wallet. This is a rather atypical, unusual EKG for a patient with hypertrophic cardiomyopathy. Can someone guess why this EKG is unusual for hypertrophic cardiomyopathy?
Maybe voltage looks normal.
Yeah, you got it right. Yes. So it's like including voltage, that's very normal, right? There's no STD changes. Yeah, things look normal. There's no LVH or strain pattern. So yeah, it's rare for patients with HCM to have completely normal EKG. It's very rare. They usually have some EKG abnormalities. So echocardiogram is the first and the most, let me just play it again, most important modality to diagnose HCM. As you can see here, this patient with HCM has pretty thick intraventricular septum here, as well as a thick posterior wall. And there is always SAM during systole. The tip of the mitral valve leaflet gets dragged anteriorly, as you can see here, dragged to anteriorly during systole. Okay. There are several other conditions that can cause LVH, and we always have to think about other conditions that can mimic HCM, hypertrophic cardiomyopathy. The differentials for HCM, hypertrophic cardiomyopathy, include pressure overload due to hypertension, aortic stenosis, subaortic membrane, and the other differential include athlete heart, so physiologic conditioning against strenuous training. Other differentials include Fabry disease and other storage diseases and cardiac amyloidosis. Shown here are examples of pathological findings from the 3 HCM mimickers. Can someone guess what this is on the left upper side? This is showing a light pink hyaline extracellular deposits displacing the cardiac myocytes. Yeah, the answer is amyloid, cardiac amyloid. How about this one showing no caseating granuloma on the right upper? So this is sarcoid, cardiac sarcoid. And the last one showing cardiomyocyte hypertrophy and perinuclear vacuoles. This is an example of Fabry disease. The other differential is athlete heart. It is sometimes difficult to distinguish between HCM and athlete's heart. Here are echocardiograms in horizontal lung axis view from an elite athlete, Olympic rower, and a patient with hypertrophic cardiomyopathy. So the interventricular septum thickness was similar in each, and this may create a diagnostic dilemma. Let me show you an example of such diagnostic difficulty to highlight the magnitude of the problem. So Eddie Curry was a high school center, pretty tall, and was a player of the high school player of the year and turned pro in 2001, and a great record, 16 points per game, 5 rebounds per game, great numbers, and then went into free agent hoping for a 60 to 70 million contract in 2005. However, he had a ventricular tachycardia event and missed 13 games of the season. And experts got together and did an echo. Echo was equivocal. They couldn't tell if that's genetic hypertrophic cardiomyopathy or just physiologic conditioning due to this basketball training, athlete heart. So 3 experts got together. One said that he should get genetic testing. He said, nope. And then Chicago Bulls, that he used to belong at that time, did not allow him to play anymore without getting the recommended genetic testing. So he was about to finish his career there, but one team took him without genetic testing and allowed him to play. Does anyone know which team took him? Hint, you're in New York? Yay, team 6, got it. You got it right, yes, New York Knicks took him. So yeah, Knicks took him and allowed him to play. And eventually he completed his career without any VT, VFib, or sudden cardiac death event. So this highlights the magnitude of how much the diagnosis of HCM and fear of sudden cardiac death could affect one person's career as an athlete. Thank you, Team 6. Tenzin, Lauren, and Ken. Thank you. All right, so HCM is classified into 2 categories based on hemodynamics. This distinction is important, not because of academic purposes, but because it does change our management, as I will discuss later. If you have significant LVOT obstruction defined as a great LVOT gradient above 30 millimercury at rest, or with provocation, this is classified as obstructive HCM or HOCA. You can provoke LVOT obstruction using several different techniques, including exercise and Valsalva maneuver. If you cannot provoke LVOT obstruction, then it is categorized as non-obstructive HCM. Now, this is an example of pressure tracing in the LV and femoral artery, representing the intra-aortic blood pressure during Valsalva maneuver in a patient with obstructive form of hypertrophic cardiomyopathy. The yellow line above here says LV shows LV pressure, and the orange line or tracings below says FA shows pressure in the artery. As you can see here, there is almost no pressure gradient, meaning no LVOT obstruction between LV and aorta before Valsalva maneuver. However, significant pressure gradient arises during and after Valsalva maneuver, as you can see here, which gradually goes down to the baseline level during the release phase of Valsalva. Now, the important point of this figure or this tracing is this. What is the lowest systolic blood pressure in the artery in this patient? So here, the systolic blood pressure goes down, and this is probably the lowest point. And the scale is that this is 0, this is 100. So it's like 20, 40, 60, 80. So what is the lowest systolic blood pressure on this peak? Can anyone tell?
That looks like 38.
Yeah, it's like below 40, right? It's like about 38. Yeah. So systolic blood pressure being 38, what happened to the patient? They may syncopate, right, with this blood pressure. So that's the point and leads to the take-home message number 3. So when you're performing Valsalva maneuver, you have to place the patient in a supine position, because if they're in a sitting position or standing position, and if you do Valsalva, then they may actually syncopate. Okay. And when making a diagnosis of HCM is challenging, cardiac MRI, magnetic resonance imaging, can be very helpful. It can measure LV wall thickness more accurately than echo. It can visualize the apex better than echocardiogram, and MRI can assess for LV fibrosis by using leg gadolinium enhancement. This is an anecdotal case of a patient who got EKG and echocardiogram for family screening purposes. So he was asymptomatic, and echo looked pretty normal. The echo wall thickness of 0.8, which is a pretty normal range. And the EKG was also essentially normal. However, we detected that this R progression, it's kind of overlapping a little bit, but our progression was reversed between V2 and V3. In normal, you should have a progression of R in V1, V2, V3. But there is a reverse R progression, and there's no other abnormality on EKG or echo. But we got an MRI just in case, just because of this reverse R progression. And that MRI showed wall thickness, wow, of 21 millimeter. About 15 is the diagnostic criteria for hypertrophic cardiomyopathy. So it's way above the diagnostic criteria. So he's got the diagnosis, established the diagnosis of HCM. So this case tells us that it is important to obtain cardiac MRI if there's any, even slightest concern for HCM based on the EKG or echo. The other test that can be useful in equivocal cases is genetic testing. We can be sure that the patient has HCM if genetic testing shows a pathogenic mutation, i.e. comes back positive. Therefore, genetic testing can be useful to rule in HCM, but it does not rule out HCM, meaning that negative genetic testing does not rule out HCM. The genetic testing panel for HCM also includes genes for a certain type of amyloidosis, Danon disease, and Fabry disease. So we can sometimes rule in or rule out these HCM mimickers based on genetic testing. All right, moving on to the part 3 of the presentation. But if anyone has any questions so far, I can take your questions, 1 or 2 questions now. You can chat or shout. Or if you don't have any questions, I'm going to move on. All right, let's move on. So I'm going to talk about the management of hypertrophic cardiomyopathy. Whenever we see a patient with hypertrophic cardiomyopathy in our clinic, we always hit these 4 points. Their activity restrictions, screening of family members, prevention of sudden cardiac death, and control of symptoms. I will start with discussing the activity restrictions. In general, patients with hypertrophic cardiomyopathy are advised against strenuous exercise, burst exercise, competitive sports, or contact sports like basketball, ice hockey, American football, and isometric exercise, for example, free heavy weightlifting. And then they're also recommended to keep themselves very well hydrated when they're doing exercise or sweating for a long period of time. The second point that we always cover when seeing patients with HCM is family screening strategies. The American Heart Association and American College of Cardiology recommend phenotypic screening with, phenotypic screening with echocardiogram and electrocardiogram to be repeated every 3 to 5 years in adults. And for children and adolescents, they recommend screening with EKG and echo every 1 to 3 years, depending on their risk. The other strategy, other than phenotypic screening, meaning echo and EKG, to perform family screening is the genotypic screening. So there are two strategies for family screening in HCM. One is phenotypic and the other is genotypic. For genotypic screening, first of all, we test the proband. The proband is the person or the patient who already has a diagnosis of HCM. And if we are lucky enough to find the genetic mutation that's responsible for this proband's HCM, then we can test this specific genetic mutation in the family members. Each first-degree family member has a 50% chance of inheriting this disease-causing mutation. And if family members have negative genetic testing, then they are confirmed to be free of the risk of developing the disease for the rest of the life. Therefore, such family members do not have to undergo phenotypic screening with electrocardiogram and echocardiogram every 5 years. One thing we have to be very careful about when recommending a genetic testing for the family member is that genetic testing results may influence insurability if the test comes back positive. There's a federal law named GINA Act, or Genetic Information Non-Discrimination Act, which prohibits insurance companies to deny insurance based on genetic testing for employment and health insurance. However, the law is silent regarding life, disability, or long-term care insurance. So we have to talk about this issue with family members before sending the specimens for genetic testing. The third point that we always review in our HCM clinic is prevention of sudden cardiac death. Because as I stated at the beginning of this presentation, HCM is the most common cause of sudden cardiac death in the young. And this is one of the examples of a young athlete who was dead on the field while playing soccer. As you know, ICDs, or implantable cardioverter defibrillators, can prevent sudden cardiac death due to ventricular tachycardia or ventricular fibrillation. However, ICDs are also associated with complications such as infection and bleeding, the need for repetitive battery changes, and the reduction in the quality of life because of fear of inappropriate shocks. Then how can we determine exactly which patient should receive ICDs and which should not? Shown here is the data comparing the event rate between ICDs placed for primary prevention and that for secondary prevention. as you can see in this graph, the event rate for patients who received ICDs for the secondary prevention. Secondary prevention meaning they had an event and received ICDs to prevent another event. The event rate is pretty high. It's reaching like 50% of receiving appropriate intervention or ICD shocks 8 years after implantation. Therefore, the guideline recommend ICD implantation for patients with prior cardiac arrest or sustained VT in patients with HCM. This is kind of easy answer because they do need AICD. They already died once. We have to prevent another death, sudden cardiac death. The problem or dilemma, sorry, let me go back. The dilemma is the primary prevention. Primary prevention means that prevention for those who never had such an event of like VFib, VTAC, sustained VTAC, or sudden cardiac death. Because as you can see on this in this graph, the event rate is relatively low. It's about 4% per year. Then how can we determine exactly which patients should receive ICDs and which should not for the primary prevention? That's a difficult part. So far, we have identified 5 major risk factors for sudden cardiac death in patients with hypertrophic cardiomyopathy. The first is the family history of sudden cardiac death. The second is personal history of unexplained syncope over the last 5 years. The third is marked, meaning more than 30 millimeter left ventricular hypertrophy. The fourth, actually these two were added in the renewal of the HCM guideline in 2020. So the fourth major risk factor is apical aneurysm. And the fifth is LV ejection fraction equal to or lower than 50%. Because usually hypertrophic cardiomyopathy patients have normal or like upper limit of normal or even hyperdynamic LV function and higher LVEF. So it's very, very abnormal for patients with hypertrophic cardiomyopathy to have abnormally low LV ejection fraction. And if the patient has one of these 5 major risk factors or one or more, then the guidelines said that ICD implantation is reasonable. If they do not have any of these 5 major risk factors, then we assess these 2 minor risk factors or predictors of sudden cardiac death, which are extensive late gadolinium enhancement on cardiac MRI, which clinically represents its myocardial fibrosis in the left ventricle. And the other is non-sustained ventricular tachycardia on Holter monitoring. So if they have one of these 2, then the guidelines say that an ICD implantation may be considered. So here is the summary of ICD implantation strategy in HCM. If the patient already had an event, such as sudden cardiac death, VFib, sustained VT, then yeah, it's class 1 indication they need AICD. So you're talking about secondary prevention here. If the patient did not have such an event, then you're talking about the primary prevention. Then you're going to turn to those 5 major risk factors. And if they have any one of those or more, then ICD implantation is reasonable. If they do not have any of the 5 risk factors, but one of these 2 minor risk factors, then an AICD may be considered. So that's the algorithm for AICD implantation. The fourth point that we always discuss at our clinic is control of symptoms. To review the pathophysiology of symptoms in obstructive form of HCM, the key point is this asymmetric septal hypertrophy. And this leads to all the consequences such as LVOT gradient, SAM, and MR. Therefore, the target of therapy, including medical and invasive in patients with symptomatic obstructive HCM is to poison the hypertrophic septum. This is why negative inotropic agents such as beta blocker and calcium channel blocker become so important in the management of obstructive HCM. The first option is always beta blocker. And if the patient has a contraindication for beta blocker or cannot tolerate beta blocker because of side effects or heart rate being too slow, we'll either substitute with or add verapamil. The third option for obstructive HCM pharmacologic therapy is disulfiramide. Disulfiramide have been developed for arrhythmias and has been around for decades. It's a very old medication. However, it fell out of favor of cardiac electrophysiologists for a while before it was rediscovered to have favorable effects in patients with obstructive hypertrophic cardiomyopathy. And the favorable effects are due to its negative inotropic effects, therefore opens up the LVOT obstruction, and the vasoconstrictive properties, therefore maintaining the blood pressure and avoiding syncope. It's been shown that disulfiramide can decrease the LVOT gradient. Now, if we have tried all of these medications and if the patient still feel symptomatic, then we have two invasive options for septal reduction therapy. One is septal myectomy. This is an open heart surgery. And what's happening in the OR during septal myectomy is that the surgeon places an incision on the aorta, through the aorta, and looks down on the LV through the aortic valve. Then the surgeon takes out a scalpel and cuts out a chunk of the hypertrophied basal myocardium to create a canal so that the blood can go through without obstruction. Okay. The other option, invasive option for septal reduction therapy for symptomatic relief of obstructive hypertrophic cardiomyopathy is alcohol septal ablation. Surgical myectomy has been around since 1958, whereas this alcohol septal ablation technology is relatively new and it has been developed since 1994. I'm gonna probably go. The actual procedure starts with selecting the appropriate septal perforator branch and occluding the branch with a balloon catheter. This is done to prevent the alcohol from going back to the LAD, which would create a massive myocardial infarction in the entire anterior wall. So after confirming that there is no backflow, we inject, we inject an intravascular echo contrast and take a look at the area with echocardiography like this to predict which area will be undergoing necrosis. Then we'll inject 100% pure alcohol into the septal artery. We usually see some effects immediately by a reduction in the LVOT gradient. This is an example of hemodynamic monitoring before and after alcohol septal ablation. You can see that there is a huge gradient between LV and aorta, which disappeared immediately after the alcohol septal ablation into the septal perforator artery. For the sake of the time, I'm gonna just skip the results or the real email that we received. And there are three, the most important thing after septal ablation is to assess for pacemaker, because the most common complication after alcohol septal ablation is conduction defects requiring a permanent pacemaker. And this is because the conduction system, or the AV node, is very, very close to the septal perforator branch, as you can see in this figure. So this brings us to the take-home message 2, number 4. The most common complication after septal ablation is conduction abnormality requiring a permanent pacemaker. This algorithm is a summary of the symptomatic management in patients with hypertrophic cardiomyopathy. As I stated, the first option is beta blocker. If we fail, or if the patient cannot tolerate beta blocker, then the second option, verapamil or dalterazine. If symptoms persist, we can try disulfiramide. If we fail medical therapy, then we're going to be talking about the invasive options such as surgical myectomy and alcohol septal ablation. And this is the final slide. What we have reviewed so far was the treatment options for obstructive form of hypertrophic cardiomyopathy. In contrast, therapeutic options for non-obstructive hypertrophic cardiomyopathy are fairly limited. We can still use beta blockers and calcium channel blockers. However, disulfiramide is not indicated in patients with non-obstructive hypertrophic cardiomyopathy. In addition, if there is no obstruction, then invasive therapeutic options such as surgical myectomy and alcohol septal ablation doesn't work, so they're not available. So I hope I have successfully conveyed these take-home messages to you. And I hope I have convinced you today that HCM is the most interesting heart disease. Thank you for your attention.
Thanks, Dr. Shimada. I really appreciate it. We'll have to give the other cardiac diseases a chance to argue for their moment in the sun. So we have a couple of minutes for questions. Before we start, I just wanted to remind everybody of Hayato Mitaka's email from Saturday morning, which highlighted the new system that Sinai has put in place this year for getting CME credits. I will put the directions in the chat, but it's, for most people, it's going to be useful to look at the original email and look at the attachments there. Basically, you have to set up a Cloud CME account, which probably most of you have already. Text your cell phone number to the account, and then between an hour before grand rounds and an hour after grand rounds, text the secret code, which today is 4926, to that number so that you get instantaneous credit. So I'll let everybody do that. I'll also let people either put their questions in the chat or unmute themselves and ask questions. Maybe while we're doing that, I can ask, I don't think we talked much about screening athletes, asymptomatic athletes with no family history for cardiomyopathy. What's the current thinking on that?
Yeah, it's actually one of the most controversial areas in the management or screening for hypertrophic cardiomyopathy. And actually the guideline recommendations are different between European and American guidelines. This kind of highlights the scarcity of data and agreement in the worldwide standard level. But typically, so they do, so for the competitive athletes like college level or professional level, typically the screening starts with physical exam and history taking, like the personal history and family history, and also EKGs. So these are pretty standard worldwide, and they have to undergo these screening strategies before participating in a competitive sport at the professional level. The controversy is if everyone needs to undergo echocardiogram, because it's, as you know, time consuming. You're talking about, I don't know how many, like thousands or like maybe millions of people across the years would have to go into the professional level athletic activities. And if they have to screen everyone with echocardiogram, then it's going to be a huge require huge time, resources, budget, and power, human resources. So that point is controversial, but we typically start with history taking, physical exam, listening for murmurs, and usually EKG, and start from there.
And there's nobody advocating for genetic testing for screening, right?
At this point, it's not a prime time. It's one, could be expensive. It's getting cheaper, but it could be expensive. And two, the interpretation is pretty difficult sometimes if you have one of those, like what we call VUS, or variants with
Unknown significance.
Unknown significance. So yeah.
Thank you, Dr. Shimada. So I have a question. What should we do if we get a patient, like we get an admission for a patient with a known like HOCM presented with like acute decompensated heart failure? Right. We are like told to like judiciously use diuretic and avoid afterload reduction as much as possible. But how would you deal with that?
Yeah. It's a great point, and sorry, I didn't have a chance to visit that point, but essentially, almost all antihypertensives or cardiac medications are relatively contraindicated in hypertrophic cardiomyopathy. Like the afterload reducing agents like calcium channel blockers, except for those diltiazem, verapamil, are relatively contraindicated. ACE inhibitors or spironolactone, etc., are relatively contraindicated, and the diuretics. So yeah, you got the answer right. The key is to carefully, if you have to use diuretics, it's okay to use. So if you believe that this patient is volume overloaded, then we do sometimes use diuretics, but we have to be very, very careful not to volume deplete the intravascular volume, because if we do, then it's going to worsen LVOT gradient. So yeah, so the answer is you have to just be careful in using diuretics and avoid afterload reductors as much as possible.
Thank you so much. Sounds good.
All right, it's 12:58. I think this is probably a good time to quit. Thank you so much, Dr. Shimada, for joining us. Always nice to have you back here. We'll hope to see you again, and we'll see everybody else next Monday at 12 as our Grand Round series continues. Thanks, everybody.
It was my pleasure. Thank you so much.